Alright, let's talk about what doctors don't really talk about when it comes to Ozempic. I want to start by saying GLP-1RAs are amazing medications, and we didn't really have good weight loss medications before them. No other weight loss medication even comes close to the amount of weight loss that we're seeing with the newer GLP-1RAs. Number one, I've seen a lot of stigma and even gatekeeping with these medications. When Ozempic went on backorder, a lot of people thought it should be reserved for diabetic patients and pushed this immorality sentiment on people using it for weight loss. Like they were stealing it from people who actually needed it. These are my own personal thoughts, but I did not agree with this. I can tell you right now, there are more drugs that we use for diabetes than I can count on my fingers. With similar outcomes in blood sugar regulation, Ozempic is not the only one. It's not appropriate to fat shame and judge people who are on these medications for weight loss. I don't think people understand how hard it is to lose weight. There are so many things that play into this, like hormones, what medications you're on, genetics, stress, sleep, environment, food deserts, time, and the physical capabilities to exercise. Weight loss can be really hard for people with PCOS, menopause, hypothyroidism, patients on antipsychotics, Remeron, and other medications. Telling people just to eat better and exercise is incredibly dismissive. Number two on my list is muscle loss. Muscle loss comes with weight loss. You need to make sure that you're still eating enough and nourishing your body, getting adequate protein. I'm a huge advocate for weightlifting. This is going to help you retain some of that muscle loss. It's good for your bones too. Gotta get your gains in, mamas. Number three on my list is weight regain. Weight regain to some extent is to be expected when patients come off of this medication. How long you stay on this medication is between you and your provider. So that's why it's important to incorporate healthy lifestyle modifications along with this medication. Meal prepping, including whole grains and complex carbs, fruits, vegetables, healthy fats, enough protein, getting enough sleep, and exercise, even if it's just taking a little walk 3 times a week. Do something that you're gonna keep doing and feel good doing. Exercise isn't meant to be punishment, which brings me to my next point. Number 4, eating disorders. Providers should be aware that those with eating disorders may want to be on Ozempic. I'll also mention that not all people with eating disorders are underweight, especially those struggling with binge eating disorder. I always stress the importance of having a therapist if you're struggling with this. Number 5, mental health side effects. There were concerns raised about a potential risk of depression, anxiety, and suicidality with GLP drugs. However, no strong evidence supports these claims. The FDA looked at a bunch of reviews, clinical trials, and studies and did not find an association between the use of GLP-1RAs and the occurrence of suicidal thoughts or actions. However, they said we cannot definitively rule out the small risk may exist. I think that these claims are likely due to confounding variables. Number 6 on my list is gastroparesis or stomach paralysis. There have been some case reports of gastroparesis with medications like Ozempic. GLPs work partially by delaying gastric emptying, and those side effects look very similar to the symptoms of gastroparesis. I'll mention that diabetes is a well-known cause for gastroparesis. Elevated blood sugar can damage your nerves. The delayed gastric emptying that we see with GLP drugs is reversible upon discontinuation, although it might take a few weeks or months. More studies are needed to determine the potential risk of gastroparesis with GLP-1 drugs. I generally recommend a slow titration and only increasing your dose when benefits subside in order to mitigate those side effects and retain efficacy long term. Number 7 is compounded semaglutide. I think y'all know by now, but I support the preparation and use of legally compounded medications by pharmacists. Pharmacists learn in school how to compound and then can specialize in this after graduation. We learn the science behind it and how to prepare compounded sterile products. Section 503A of the Food, Drug, and Cosmetic Act allows us to compound commercially available drug products if those products are on shortage. You can compound a commercially available drug product that is not on back order if you make an alteration to the drug product that meets a specific clinical need. For example, a drug has a red dye in it, that patient needs that drug, you can compound that drug without the red dye. But I've had patients ask me, once this drug comes off a back order, can they still get it? I personally think if it has some vitamins in it that mitigates the nausea vomiting, yeah. These are my own personal thoughts, but I think that that would create a clinically relevant difference for those patients. I know of a lot of patients doing really well in the compounded version and they can afford it. $1,200 a month is not in the budget for most people. Drug companies are really mad that compounding pharmacies are undercutting them, by the way. As some of you guys know, injectable semaglutide was removed from the FDA's shortage list. The FDA sent this notification out on February 21st. They address compounded semaglutide if you scroll down. To avoid unnecessary disruption to patient treatments and to help facilitate an orderly transition, FDA does not intend to take action against a compounder that is not registered as an outsourcing facility, basically a 503A compounding pharmacy, for compounding, distributing, or dispensing semaglutide injection products that are essentially a copy of commercially available drug products within 60 days of this decision. It looks like outsourcing facilities get a 90-day wiggle room. This is 503B. This is to allow patients time to transfer their prescription in order to prevent gaps in treatment, to allow pharmacies to adjust to increasing demand, and basically to allow compounding pharmacies to sell off the rest of their product. But yeah, let's look at number 8 on my list. Number 8 on my list is the black box warning. In rodents, semaglutide causes dose-dependent and treatment duration-dependent thyroid C-cell tumors at clinically relevant exposures. So cancer in rats. Unknown whether it causes this in humans. C-cells are also known as the parafollicular cells. They secrete a hormone called calcitonin that majorly regulates blood calcium levels. In 2023, a systematic review and meta-analysis was published about this. For those of you that don't know, meta-analyses and systematic reviews are the strongest or highest level of evidence. This looked at a ton of different randomized control trials and a large population of patients. Conclusion: semaglutide use in randomized control trials and real-world studies was not associated with an increased risk of any types of cancer. Conclusion is supported by a high grade of evidence. A limitation that the study brought up was that the maximum follow-up duration was about 18 months. Carcinogenesis is often a slow process over many years to decades. Although there was no funding or disclosures or conflicts of interest for this paper specifically, it looks like all 37 randomized control trials reported conflicts of interest, especially pharmaceutical funding. I take this with a grain of salt because drug companies are usually the ones conducting and funding these studies. Most drug trials are industry funded. That being said, patients have the right to know that there's a black box warning. When initiating any medication, we're weighing potential risks against benefits. The FDA can choose to remove this black box warning once more literature comes out. Number 9, cardiovascular benefits. Let's look at this study. Semaglutide and cardiovascular outcomes in obesity without diabetes. Double-blind randomized placebo-controlled trial. We looked at the dose of 2.4 milligrams of semaglutide versus placebo. Mean follow-up was approximately 40 months. This chart is interesting. It shows death from cardiovascular causes, non-fatal myocardial infarction or heart attacks, and non-fatal strokes. We can obviously see that there's a higher risk in patients who are on the placebo versus those on semaglutide. In patients with pre-existing cardiovascular disease and overweight or obese but without diabetes, semaglutide reduced the incidence of death from cardiovascular causes, non-fatal myocardial infarction, and non-fatal stroke. So mortality and a morbidity benefit. Number 10 on my list, Ozempic babies. Fertility may increase with the positive effects of Ozempic, so weight loss and blood sugar management. There have been concerns with a potential interaction with oral birth control. I've mentioned this in a video before, but we do not yet have a definitive answer as to whether or not Ozempic decreases the efficacy of oral birth control. One study published in 2014 showed that semaglutide did not reduce the bioavailability of combined oral contraceptives. This was looking at ethinyl estradiol and levonorgestrel. I will mention in 2023, one review did look at the impact of tirzepatide on oral birth control. This is Mounjaro and Zepbound. It's more potent than semaglutide or Ozempic. They looked at 6 different articles. Here we're looking at Trulicity, Victoza, Ozempic, Mounjaro, and Zepbound. Exenatide and Ozempic again. Tirzepatide was the only one that showed a decrease in area under the curve. So in conclusion, these drugs may affect the pharmacokinetics of hormonal contraceptives. So it doesn't hurt to counsel a patient on backup contraception when it comes to tirzepatide, Mounjaro, Zepbound. We do need more studies though. Remember, the remaining 5 studies involving the GLP-1RAs did not show a statistically or clinically significant difference of impact of the agents on oral hormonal contraceptives. And last on my list, number 11, efficacy with alcohol use disorder. This is a small study that looked at semaglutide and reducing alcohol cravings. It looked at 48 people and it was over 9 weeks. Here we see that treatment with semaglutide reduced weekly alcohol cravings, reduced average drinks on drinking days, and led to greater reductions in heavy drinking days. Here we see that 40% of patients receiving semaglutide reported no heavy drinking days versus 20% with the placebo group. It's on my radar to see bigger trials with this. I expect some promising results.